Good afternoon, everyone. Welcome to this session on Essentials of Disaster Planning. This module shifts our focus from assessing risk to the proactive steps we take to manage and mitigate it. We are moving from the analytical to the operational. Let's start with the introduction. Disaster planning essentially aims to anticipate potential threats, coordinate preparation efforts, and solve complex operational problems before they occur. We aim to achieve several fundamental goals. First, to minimize morbidity and mortality. This is the primary humanitarian objective. Second, we must protect critical assets, such as specialized medical laboratories or regional supply chain hubs. Third, we strive to prevent secondary crises, such as infectious disease outbreaks following a major flood. Finally, successful planning should enhance community resilience, ensuring the population can bounce back quickly and effectively. Public health is the backbone of the community-level response. Our core task is to establish traditional planning principles for public health services during disasters, ensuring continuity of care. We must partner with community management for both response and recovery, integrating health concerns into all aspects of emergency management. This requires us to participate in community disaster preparation planning alongside government agencies, NGOs, and the private sector. Furthermore, public health organizes, prepares, and coordinates with clinical and non-clinical partners, ensuring seamless integration between hospitals, mental health services, and community-based support groups. In the U.S., these frameworks mandate a structured approach to preparedness. Key documents and agencies include the PHEMP, Pandemic and All Hazards Readiness Act, which drives proactive planning for various threats. Federal policy simplifies dealing with medical management and treatment across state lines. The structure facilitates rapid distribution of critical countermeasures like pharmaceuticals and medical supplies. Federal bodies promote healthcare worker readiness and responder capabilities, often through specific training programs. Agencies like the HHS National Health Security Strategy guide long-term planning. The goal is always to bolster healthcare infrastructure before a crisis, mitigate hazards, and enhance support services for effective long-term recovery. Let's illustrate how public health fits into the national response architecture. The ESF 8, or Emergency Support Function 8, which covers public health and medical services, is our operational home. This function is guided by the Regional Emergency Coordinator, or CDOs, who coordinate regionally. Health planning is integrated with the state and local preparedness policy and plans, ensuring full coordination with local agencies. Finally, the CDC planning branch focuses on critical areas like chemical, radiological, and epidemiological crisis response, providing specialized expertise and resources. Now let's delve into the actual process, starting with the principles of disaster planning. These principles ensure our plans are robust and usable. First, we acknowledge that disasters differ from daily emergencies. They overwhelm routine systems and require extraordinary measures. Therefore, plans must be plain, concise, and understandable to all responders. They must be flexible and adaptable. A plan for a wildfire must be adaptable to a sudden severe windstorm. Our planning must be based on known behaviors and assumptions. We must anticipate the predictable surge in demand for resources. Plans must be developed with community partnership, ensuring buy-in and relevance. And finally, the local response is the primary focus, with federal support acting as a supplement. Let's explore the three critical components of planning approaches. All hazards planning. This is our default approach. Instead of writing a separate plan for every single scenario, we develop a generic plan that addresses the common problems across all disaster types: shelter, communication failure, supply chain disruption, etc. For example, a common plan for securing vital records will work for both a flood and a power outage. Specific scenario planning. Where the risk is unique and highly localized, we develop plans for specific high-impact local threats. For a city with a major petrochemical facility, a detailed specific plan for a massive toxic release would be necessary, as the response protocols, decontamination, specialized antidotes are not generic. PHP grants. Plans must integrate with the funding mechanism provided by PHP grants, ensuring our operational goals align with available financial support. Considering the common tasks in disaster response. When a disaster strikes, certain functions are universal. They are broken into two main groups: operational focus, interagency coordination, getting disparate groups like fire, police, and public works to work together under a unified command; communication and information sharing, ensuring the public and responders have accurate, timely information; triage and patient tracking, rapidly assessing who needs care and where they are going; resource management and distribution, managing the supply chain for everything from water bottles to ventilators; care for damaged healthcare infrastructure, rapidly establishing field hospitals or alternative care sites; humanitarian focus, surveillance and forensic management, monitoring for disease outbreaks and managing remains; protection or quarantine, implementing non-pharmaceutical interventions like isolation if needed. Reiterates these core tasks, emphasizing the need for search and rescue operations, triage and patient tracking, a task so critical it bears repeating, and the need for continuous resource management and distribution. These actions are all interwoven to save lives and stabilize the situation. These tasks inform the structure of our documents, outlining the essential components of a disaster plan. A good plan is methodical. It must identify and define the jurisdiction and agencies involved. It needs to assess community demographics and health status. Knowing where the most vulnerable people are is key. It needs to identify functional needs and vulnerable populations, like dialysis patients or those requiring oxygen support. We must map healthcare facilities and stability resources, noting their capacity and structural integrity. It establishes clear communication protocols for internal and external audiences. Finally, it must include procedures for all essential assistance functions, from mass feeding to temporary sheltering. A critical logistical challenge is surge capacity. This is defined as the ability to treat a sudden, massive increase in patients or conduct deep-scale assessments. Successful surge planning requires several components. Planning logistics, ensuring transportation and supply chains can handle the sudden demand. Regional coordination, sharing resources like specialized trauma surgeons or ambulances across neighboring counties or states. Alternate care sites, quickly converting non-traditional spaces like gymnasiums or university halls into functioning medical or shelter facilities. Staffing projections and training, having pre-identified pools of personnel, including retired professionals or volunteers, ready to be activated. Resource allocation systems, predetermined procedures for distributing critical supplies like ventilators in a situation of extreme scarcity. Let's acknowledge the reality that we must be delivering care under extreme conditions. This presents several challenges. A loss of utilities, power, water, infrastructure, roads and bridges, and medical records is highly likely. Responders face self-damage and injury limitations. They are affected too and cannot always be relied upon. There will be a high patient surge, including delayed or walking wounded patients who arrive days later. Contingency care, providing care that is below standard when necessary, making difficult ethical decisions. Crisis standards, ethical, operational, and legally required frameworks that guide resource allocation under extreme duress. This environment mandates that all staff be trained, capable, and legally qualified to perform their assigned roles. One of the best ways to prepare for these challenges is through training exercises that test the effectiveness of disaster plans. Exercises are the practical application of the written plan. Their types include tabletop discussions, seminars, drills, and large-scale, full-scale field operations. They are designed to identify weaknesses and gaps in the plan, allowing for corrective action. The HSEEP Homeland Security Exercise and Evaluation Program standardization ensures that all exercises follow a common format and provide measurable results, aiding continuous improvement and training. This reminds us that planning must be inclusive, particularly focusing on vulnerable populations in planning. Public health must ensure that the specific needs of vulnerable individuals and populations are explicitly included in the plan. This requires us to identify community-specific emergency needs that may not be obvious, such as the need for sign language interpreters or specialized infant formula. We must facilitate outreach and communication using accessible formats and languages. And critically, we must ensure accessibility and inclusivity in shelters in all care, ensuring people with disabilities or chronic conditions are not overlooked. Finally, disaster planning is essential to an effective public health response. The plan must cover key capabilities like surge capacity and resource management. We must have mechanisms for effective coordination and communication. The planning must rigorously account for vulnerable populations and include routine exercises and training to validate and improve the response framework.